Okay, so we'll discuss magnesium. It's the fourth most abundant cation in the body, and it's the second most abundant intracellular ion. Okay, and regarding distribution, 53% is found in bone, 46% is present in muscle and other organ and soft tissue, and only less than uh, 1% is present in serum or plasma and red blood cells. Okay, so regarding the forms of uh, magnesium, one third is bound to protein, and two thirds is ionized, and only 5% of the two thirds is complex with other ions. Okay, now what are the functions of magnesium? So first, it's a cofactor of more than 300 enzymes. So for example, the enzymes needed in the conversion of inactive form of vitamin D to its active form, you need vitamin D, okay, to activate those enzymes. So regarding magnesium, it is an important activator of enzymes or important cofactor, okay, of more than 300 enzymes. Now, what are the other functions of magnesium? It is also responsible for cardiovascular, metabolic, and neuromuscular health, and it also maintains the structures of DNA and RNA, and it also regulates movement of potassium across myocardium. Okay. Now, for the regulation of magnesium, so first hormone of PTH. So for PTH, it increases renal reabsorption of magnesium and enhances the absorption of magnesium in the intestine. So PTH increase reab and ab of magnesium. The next, aldosterone and thyroxine. So aldosterone from your renal cortex and thyroxine from your thyroid gland. So these hormones increase renal excretion of magnesium. Okay, so PTH is to increase magnesium concentration. Aldosterone and thyroxine is to decrease magnesium concentration. So for the diseases, first you have hypomagnesemia. So it's frequently observed in hospitalized individuals, in intensive care units, or those receiving diuretic therapy or digitalist therapy. It's rare to occur in patients that are not hospitalized or non-hospitalized individuals. And uh, reduced intake of magnesium is the least likely cause of severe deficiencies. Okay. So for hypomagnesemia, there are gastrointestinal disorders that can cause decreased absorption of magnesium. Okay. And for renal disorders, if there's kidney disease, usually the magnesium level is decreased because of increased excretion of magnesium. Okay, so that's for hypomagnesemia. So GI disorders and renal disorders. Another, if there's hyperparathyroidism and hypercalcemia. So PTH is important for the reabsorption and absorption of uh, magnesium. But if the patient or the individual has hyperparathyroidism, meaning there is excessive production of PTH and hypercalcemia occur, then that condition or those conditions uh, will eventually cause increased renal excretion of magnesium. Okay, because there's excessive amount now of calcium ions in the body. So to maintain electron neutrality, you need to remove some of the magnesium. Okay, so that's for hyperparathyroidism. Okay, so next is hyperaldosteronism. So if there's hyperaldosteronism, remember aldosterone promotes the reabsorption of sodium. So there is increase in sodium if there's hyperaldosteronism. But aldosterone, the second effect of aldosterone is reaction is to increase the excretion of magnesium. So if there's hyperaldosteronism, there's increased excretion of uh, magnesium. Okay. Now, another is regarding that hyperaldosteronism. If there's hyperaldosteronism, there's also increase in water retention. So this water retention is the second, okay, cause of the decrease in magnesium level. And that is the cause of pseudo-hypomagnesemia. Meaning, there's dilution, okay, of magnesium due to increased water retention, okay, in hyperaldosteronism. Next, for hyperthyroidism, there's excessive production of thyroid hormones, and thyroid hormones thyroid hormone increase renal excretion of magnesium. For diabetes, it's usually associated with polyuria or excessive urine formation. Another, you have diuretics, gentamicin, cisplatin, and cyclosporin. These drugs increase or there is elevation or renal loss. There's increase in the renal loss of magnesium. Another is excess lactation, increase uh, use and loss through milk production. Okay, there is loss of magnesium through milk production. Okay, so these are the causes of hypomagnesemia. Okay, so symptoms of hypomagnesemia. So usually the symptoms of hypomagnesemia are associated to cardiovascular and neuromuscular. So there's a presence of cardiovascular and neuromuscular symptoms. And the problem or the cause of this one is that magnesium is the activator or cofactor of ATPase enzyme. So if there's a problem with magnesium, there's also a problem with the sodium potassium pump. Okay, so the effect, there's decreased intracellular potassium concentration. So there is increased excitability and may lead to cardiac arrhythmias. Another is the presence of muscle weakness, tetany, paralysis, or coma. And regarding magnesium, magnesium is needed in muscle contraction. That's why if there's hypomagnesemia, the effect is prominent in muscles. Okay. Now, regarding hypomagnesemia, it can also cause hypocalcemia. Okay, why? Because magnesium deficiency can impair the release of PTH. So, if there's magnesium deficiency, it can cause problem with the production of PTH or the release of PTH. So, if there's decrease in release of PTH, the calcium concentration is also affected. So, there is hypocalcemia. Okay. Okay, so treatment of hypomagnesemia, oral intake using magnesium lactate, magnesium oxide, magnesium chloride, or an antacid that contains magnesium. Okay, for severely ill patients, they need parenteral administration of magnesium sulfate. Okay. Okay, so for hypermagnesemia, this meaning there's increase in magnesium concentration. It is observed less frequently than hypomagnesemia, and common cause is renal failure. Okay, so most severe elevations are usually due to the combined effects of decreased renal function and increased intake of commonly prescribed magnesium-containing medications such as antacids, enemas, or cathartics. Okay, so usually antacids contain magnesium. Okay, and if you're constant in taking antacid and you have renal failure, those two conditions or those two, uh, no, a renal failure, that's a condition, and the use of antacid, those two things can cause hypermagnesemia. Okay. Another, if there's a decrease in thyroxine and growth hormone, and also decrease in aldosterone. Okay, so regarding decreased thyroxine, thyroxine promotes the excretion of magnesium. Okay, so if there's a decrease in thyroxine, there's a possibility of magnesium to accumulate in the system. Same with growth hormone. Okay, and aldosterone. Okay, next is the use of magnesium sulfate to treat preeclampsia, cardiac arrhythmia, or myocardial infarction. So preeclampsia is hypertension in pregnant women. Okay. So for myocardial infarction, meaning of infarction is death of tissue. And the reason why there's death to the tissue or a certain portion of the heart, if this is the heart and you have uh, a blood vessel full of or this is an atherosclerotic blood vessel. So that blood vessel cannot supply oxygen to this area. So it's because of this obstruction, there's death of the tissue present in this area. So that's infarction. So to uh, treat that one or try to revive those cells, we need to perform reperfusion. Meaning of reperfusion, we try to supply uh, that affected area with oxygen. But we need to retain or uh, basta, imo siyang ibalik or retain ang flow of blood. The reason why there's obstructions because of atherosclerosis, diba? So you are trying to supply blood to that area using magnesium because magnesium is a vasodilator, so it increases the opening. So there's a possibility nga the blood will flow again, okay, to that particular area or portion of the heart. Okay, that's for reperfusion. Now, the problem with this therapy or treatment, you're introducing magnesium sulfate. So there's a possibility that it can cause maternal hypermagnesemia and neonatal hypermagnesemia for patients or pregnant patients nga with preeclampsia. Okay. Neonatal hypermagnesemia is common due to the inability of the kidneys of that newborn to process magnesium. Okay, the kidneys are not that efficient in processing magnesium, so it can cause accumulation. Okay, uh, of 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 magnesium. Okay, in the circulation. Okay. Next is dehydration. So it can cause pseudo hypermagnesemia. So there's increase in magnesium due to the decrease in plasma volume. Another, you have multiple myeloma, bone carcinoma, and metastasis. It's due to increased bone loss. So there is also the release of magnesium from bones. Next, you have the determination of magnesium. So for determination of magnesium, acceptable specimen, you have non-hemolyzed serum and the use of lithium heparin. Okay, you're not allowed to use oxalate, citrate, and ETA because these anticoagulants chelate calcium and magnesium. Okay, so another, if there's hemolysis, hemolysis can cause false increase in the concentration of magnesium. Okay, it's because it's present usually in the intracellular space. Okay, magnesium. So for the methods, first you can perform colorimetric. So using calgamide, formazine dye, and methyl thymol blue. Okay, so um, it's just an example. These methods are usually dye binding method, meaning you're going to add magnesium, which is present in your serum, plus the reagent, and it will form or it will develop a color. So for example, if you're using calgamide plus magnesium, the result will be reddish violet color complex. Okay, so you read that at 532 nanometers, then you have the concentration of magnesium. The intensity of the color is directly proportional to the concentration of magnesium. Okay, but the reference method for magnesium, it is atomic absorption spectrophotometry. The same with calcium. Okay, so I think that's all for our discussion regarding magnesium. Thank you and God bless.